Today's video we'll talk about jaundice. So the definition of jaundice is it is a yellow discoloration of skin, mucous membrane, sclera, conjunctiva. Now this occurs due to increased serum bilirubin levels. Now, it is clinically detectable if the serum bilirubin level exceeds 2.5 milligram per deciliter. The first clinical sign or the first yellowish discoloration is seen in sclera. Now, coming on to the classification is based on a number of factors. First is based on the color of sclera. If it is yellowish, it is medical jaundice, and if it is greenish it is referred to as surgical jaundice. Now coming on to the another classification which is based on etiology of jaundice. It can be hemolytic, it can be obstructive, and it can be hepatic. Then coming on to the basis of chemical nature of pigment bilirubin, it can either be conjugated or unconjugated. Now etiology, we will discuss the etiology in two different headings. The first one is unconjugated and the second one is conjugated. Now in unconjugated, either it can occur due to hemolysis or it can occur due to the decreased uptake, or it can occur due to the decreased conjugation. Now, in hemolysis, there can be a number of factors like intracorpuscular hemolytic anemia, or there can be hemophilic disease, drugs. Then, in decreased uptake, drugs, sepsis. In decreased conjugation of bilirubin, usually occurs in neonates and Gilbert syndrome. Now, in conjugated, it can occur either intrahepatic or it can occur extrahepatically. Intrahepatic or extrahepatically. In intrahepatic, basically the diseases of liver. So, cirrhosis of liver or primary biliary cirrhosis, or we can encephalopathy, then drugs, Hodgkin's lymphoma. Over here in extrahepatic, outside the liver, so bile strictures, obstruction, tumors, pancreatitis, colodical cyst, some parasite. Moving on to the pathophysiology of jaundice. So first of all, in jaundice, always remember, first of all, there will be erythrocyte breakdown. Now, it can be due to a number of reasons like hemolytic anemia, sickle cell anemia, hemolysis, or also malaria. Now, if the erythrocyte breakdown has happened, so it is a state, it is pre-hepatic, okay, pre-hepatic or hemolytic anemia. Now there will be an increase in the unconjugated bilirubin. Now this unconjugated bilirubin can also increase due to the Gilbert syndrome, as I discussed before, due to which there will be a decreased excretion and hence an increase in the unconjugated bilirubin, right? So this is ultimately leading to jaundice. Now if we have hepatitis or hepatic cellular carcinoma in the liver, so it is going to do liver damage, so it is intrahepatic, basically hepatic, so this is also going to lead to jaundice. Now if I have some conditions like pancreatitis or cholecystitis and many more, and there occurs fibrosis, okay, and there is swelling, so this is basically intrahepatic, so there is an increase in the conjugated bilirubin, so it will lead to jaundice, right? So I've discussed all the different types with their pathophysiology. Now coming on to the clinical evaluation of jaundice. Now in history, we take the duration of jaundice, blood transfusion or IV drug abuse or unprotected um, sexual intercourse. Then also we will see if there is any change in the appearance or the color of the stools. Then we also take the history of the drugs taken. Then if there is pruritus, There is, if there is history of pregnancy, if there is epistaxis or hematemesis, if there are symptoms of encephalopathy. Now, coming on to the physical signs. To remember the physical signs, we will remember an acronym which stands for CARES, CAP, has, xanthoma. Okay. Now, cares, by cares, we will remember that there is a Claire's Fletcher ring on ophthalmoscopic examination. By C we will remember cirrhosis. By A, we will remember ascites. By P, we will remember pulse rate. By H, we will remember hepatomegaly. By A, we will remember anemia. By S, we will remember splenomegaly. And xanthoma for xanthoma. Okay, cares, cap, has xanthoma. Now coming on to the clinical workup of a patient of jaundice. Now we know that jaundice occurs due to a number of reasons, right? So there are different characteristics of jaundice which we classify, and suppose if the signs and symptoms are the person has fever, also he has anemia, he has tender hepatomegaly, anorexia, a distaste to food, smoking, and jaundice. So, the basic probable diagnosis will be acute hepatitis or drug induced, or it can also be a hepatic abscess. If the person has IV drug abuse history, or the person is hemophilic, or the person is a male who is homosexual, or he has hepatomegaly. So the probable diagnosis will be chronic hepatitis. Also, it can be acute hepatitis B and C. Now, if there is a patient who has hepatomegaly and jaundice, plus he has black colored urine and stools, black colored urine and stools. Now, by the color black, you have to remember that by the color black, it is hemolytic. Okay, black is hemolytic jaundice. Now, if the person has white clay colored stools, now by white colored clay stools, it is either cholestasis or it is biliary cirrhosis. Now, if there is fluctuations, so if fluctuations are present, then the patient is seen to have the fluctuations as well as abdominal pain. So there will be bile duct obstruction, or there can be pancreatitis. Okay. Then if the patient has tender hepatomegaly, then then the patient might have hepatic malignancy. Now if the patient has one if the patient has ascites, he has splenomegaly, and if he has engorged veins over abdomen, so this is portal hypertension. Now if jaundice, hepatomegaly is all present, also he has some signs of encephalopathy, so he will have hepatic encephalopathy, which we will discuss in another video. Now if it is jaundice with pregnancy, then it can either be a hepatitis or cholestatic. Now if it is recurrent, then it is congenital. Okay. Now coming on to the next part, which is biochemical and other abnormalities. We will remember this by a acronym though, but you can remember some points. It is not important to remember all. So first of all, the first point we will remember is PBF. Now in PBF, there will be abnormal RBCs in hemolytic, remember, and then this could be normal and this could be normal. Now coming on to the hemoglobin. Hemoglobin will be decreased or no problem or increased, right? So HP. Then for urine, for urobilinogen, this is present, present, absent. Then we have stools for stercobilinogen. This will be present, this will be absent. Now coming on to urine for bile, salt, and pigment. This will be minus, plus or minus, plus. Then we have T, total bilirubin. This will be 5 to this will be 3 to 5 milligram, this will be 5 to 10, and this will be 10 to 15. Then we will have type of hyperbilirubinemia. This is unconjugated, conjugated, conjugated. Then we have by A, alkaline phosphatase, normal, normal, increased. Then we will have serum cholesterol. This will be normal, normal, and increased. Then we have serum transaminase. This is also same, but this is increased in hepatocellular, and this will be normal. Okay. Then we have PTI, which is normal here, abnormal, and normal. Then ultrasound of liver. In this, the liver will be enlarged, the same, and in this it will be enlarged. Now a very important point to refer here is what is the difference between unconjugated bilirubin and conjugated bilirubin. Okay, so first of all we come to water solubility. In water solubility, unconjugated is not soluble and conjugated is soluble. Then coming on to the affinity for lipids, it has, it doesn't. Then coming on to van Bergton test. It is nil in unconjugated and positive in conjugated. Then coming on to R stands for renal excretion. Unconjugated is not excreted, it is excreted. Then coming on to the reversibility of binding to albumin. It is high, it is low. Now in treatment it depends upon the cause. If it is due to anemia, then iron supplements are given. If it is due to hepatitis, then anti-hepatitic drugs, vaccinations are given. And if it is due to other reasons, it basically depends upon the underlying cause and the treatment. If suppose it is due to obstruction, so surgery. Okay, here antiviral, anti-hepatic, and corticosteroids can also be given. Also, if it is drug induced, then we must find an antagonist against them and use it. Also we refer some hepatoprotective drugs. This completes jaundice. In next video we will complete another topic.